All right, party people, we are back at it with another one. Let's get it. If I was to give you a patient, male, 60s, with rheumatoid arthritis and 2-month history of abdominal pain, his meds are a statin as well as naproxen, how would you treat this patient? 3, 2, 1, boom. All right, let's see why the correct answer was correct and the incorrects were incorrect. All right, for starters, this patient had rheumatoid arthritis as well as abdominal pain. He's on an NSAID. NSAIDs decrease prostaglandin synthesis by inhibiting cyclooxygenase, COX. Prostaglandins are essential for maintaining the mucosal barrier of the stomach, so the patient likely has gastritis or a gastric ulcer. The precise diagnosis isn't the issue here. It's the disruption of the mucosal barrier due to the NSAID use. So naproxen is the NSAID in question. Now, for whatever reason, the USMLE really likes naproxen. It pops up all the time. There's tons of NSAIDs that could have been used, like ibuprofen or diclofenac. But for whatever reason, naproxen is constantly there. So you have to be able to recognize this. Now, going through the option choices, misoprostol was the correct answer. It's a PGE1 analog that helps restore the gastric mucosal lining. This is especially useful in NSAID-induced gastritis or ulcers. Even if you can make arguments for other choices, this is the very clear mechanism. NSAIDs reduce prostaglandins, misoprostol replaces them. It's a clear-cut, strong, high-yield connection. As far as bismuth, it's a second-line treatment for H. pylori. The first-line treatment for H. pylori is CAP, clarithromycin, this is a macrolide, amoxicillin, and a PPI, a proton pump inhibitor like omeprazole. If after 4 weeks of treatment the patient still tests positive on the urease breath test, we assume resistance. So we maintain the PPI, but we switch the antibiotics to tetracycline, metronidazole, and bismuth. You do not need to memorize second-line therapy, but you do need to memorize the first-line agents. Esomeprazole is used in a 2-week trial for suspected GERD. So they'll give you a dude with heartburn after meals while lying down. Classic GERD. PPIs are the treatment of choice. H2 blockers may be correct in some situations. If both H2 blockers and PPI are listed, always pick the PPI. As far as metronidazole, it's part of the second-line treatment for H. pylori. Its mechanism of action is that it forms toxic metabolites that damage DNA. You have to remember that metronidazole is treatment for Giardia, Entamoeba histolytica, trichomoniasis, Gardnerella vaginalis, as well as anaerobes below the diaphragm, and H. pylori. Please note that metronidazole was once used for pseudomembranous colitis. However, since 2018, oral vancomycin is the preferred treatment. As far as sucralfate, this is a coating agent for ulcers. It forms a barrier over them. A key detail is that PPIs reduce the effectiveness of sucralfate. This is likely due to the fact that a low pH is required for sucralfate to properly cross-link and adhere to the mucosa. So if a patient notes decreased efficacy of sucralfate when used with a PPI, this would be the reason why. Just to wrap it up, naproxen reduces prostaglandins. This in turn disrupts mucosal lining. Misoprostol replenishes prostaglandins and restores that lining. That's the key here. All right, that's it for this one. Go crush it.